Hi everyone, welcome to our CPD series. And today we have our special guest from Pakistan, Dr. Manur Shokat. She is working as a clinical physical therapist in Maruf International Hospital. And thank you so much for sparing some time for us and uh, just explaining some of the things about your experience and your expertise regarding cervicogenic headache and what possibly we can add in between the discussion and what further we can get comments or updates from the audiences as well. So thank you, Manur, for having us and thank you for being here with us.
Assalamu alaikum. Hello. Thank you so much for inviting me and giving me this chance to be a part of these valuable discussions. So I'll be starting with my presentation. Okay. First, I'll share my screen.
Good luck, Manur.
Thank you.
Welcome.
Can you see the screen?
Yes. Yes.
Can you? Okay. Okay. So the topic of discussion for today is a cervicogenic headache. So cervicogenic headache is a chronic headache that arises from the atlanto-occipital or the cervical joint, and it is perceived in one or more regions of the head or the face. It is considered as the one of the rare chronic headache condition, which occurs in 1 to 4% of population which are having chronic headaches, and a cervicogenic headache is considered as a common cause of the chronic headache, which is often misdiagnosed. Mostly, it is misdiagnosed with the migraines because of its similarity of symptoms with the migraines. So, the presenting features of a cervicogenic headache they can be complex and similar to many primary headache symptoms that are encountered daily. The main symptoms of the cervicogenic headache are a combination of unilateral pain, ipsilateral shoulder, and arm pain. Range of motion in the neck is reduced, and pain is mostly relieved by anesthetic blockers. As per the International Headache Society, the cervicogenic headache is characterized as the secondary type of headache, and it is hypothesized to originate due to the nociception in the cervical area. Coming towards the cervical clinical anatomy of the cervical spine, as we know that the cervical spine consists of seven cervical vertebrae, C1 to C7, and eight cervical nerves, which is C1 to C8, along with muscles and ligament. So the first two vertebra of the cervical spine are different in shape and function comparative to the rest five cervical spine. The C1, which is called as atlas, it supports the skull and attaches at the base of the skull and forms atlanto-occipital joint and participate in 33% of the flexion and extension movement. Along with that, the C2, which is called axis, it attaches with the atlas and form the atlanto-axial joint and helps in the 60% movement of the cervical rotation. The five cervical vertebrae that make up the lower cervical spine, C3 to C7, are similar to each other, but they are very different from the C1 and C2. So, coming towards the pathophysiology of the cervicogenic headache. So what happens in the cervicogenic headache is this, that it is considered that there is pathology in the first three cervical vertebrae, C1, C2, and C3, which leads to the irritation of the C1, C2, C3 nerves. And due to the irritation of these nerves, pain signals are relayed through the nociceptive nucleus, which is the trigeminocervical nucleus, which causes pain in the occipital area and the eye. It is also considered that due to the cervical disc pathology, there is presence of aseptic inflammation and the neurotransmission within the C fibers, which leads to the worsened pain in a cervicogenic headache. As we all know that C fibers are responsible for the are the nociceptive fibers, and they are responsible for the nociception. So the activation of these fibers are are what which leads to the activation of pain in the suboccipital region, temporal region, and the eye as well. Along with that, the trigeminocervical nucleus also receive afferents from the trigeminal nerve as well as the upper three cervical nerves. So, in case of a neck trauma, whiplash, strain, or a chronic spasm of the scalp, neck, or shoulder muscle, there is increased sensitivity of the area, which is similar to allodynia that is seen in the late chronic migraine as well. A lower pain threshold makes the patient more susceptible to the more severe pain. For this reason, early diagnosis and therapeutic intervention is very important. So, I'll be discussing a little bit about the epidemiology. A cervicogenic headache, as I discussed in the beginning, it is a rare chronic headache, and it occurs in people between age group of 30 to 44 years old, and its prevalence among the patient with headache is 1 to 4%, and it depends on how many criteria is fulfilled and based on many different studies. Okay, so one thing which is seen with these in patients having cervicogenic headache is this: it affect male and female about the same ratio, which is of 0.97, and the age while the age of onset of cervicogenic headache is in the early 30s, but the age at which hello
I'm
hello
saying I agree. I fully agree.
Okay.
I can imagine.
But the age at which patients seek medical attention and diagnosis is 49.4. When compared with the other headaches these patients have pericranial muscle tenderness on the painful side, which is very commonly seen while we are doing the palpatory assessments. Coming towards the etiology of the cervicogenic headache, a cervicogenic headache, it is thought to be referred pain which arises from irritation caused by the cervical structure innervated by the first three cervical nerves. Therefore, any structure which is innervated by the first three spinal nerves could be a source of cervicogenic headache, and they may include the joint, disc, ligament, and the musculature. The lower cervical spine, it plays an indirect role in the pain production if dysfunctional, but there is no evidence of direct referral pain. Through controlled nerve blocking of various structure in the cervical spine, it appears that the zygophysial joint, especially those of C2 and C3, are the most common sources of the cervicogenic headache. This finding is even more common in patients with a history of a whiplash injury. So, what is the clinical presentation of patient with cervicogenic headache? The patient will be complaining of a unilateral dominant headache. The pain will be exacerbated by constant sitting in a constant posture or with a specific neck movement. There will be tenderness in the upper three cervical spine joint, upper three cervical joint, which will be associated with neck pain or dysfunction. And definitive diagnosis is made through selective nerve blocking through injection of specific sites. Compared to migraines and control group, cervicogenic headache group patient tend to have increased tightness at trigger point in the upper trapezius, levator scapulae, scalenes, and suboccipital extensors. There will be weakness of the deep neck muscles and increased activity in the superficial flexor muscles. Atrophy in the suboccipital extensors will be seen. So the deep muscle sleeve, which is important for the active support of the cervical segments, will be impaired. Upper trapezius, sternocleidomastoid, scalenes, levator scapulae, pectoralis major and minor, and short suboccipital extensors have been implicated. Um, then I'll be discussing about the differential diagnosis of cervicogenic headache. It is important to differentiate from serious pathologies such as vascular pathology of the neck, intracranial pathology, cervical instability, cervical myelopathy, and occipital neuralgia. It is also important to differentiate from other type of headaches such as cluster headache, tension type headache, and then migraine, which is occurring without an aura. So, what is cluster headache? As it is most similar with other type of headache. I will discuss a little bit about these type of headaches. So it is easier for us to differentiate between cervicogenic headache and the other type of headache. The cluster headache, it is unilateral, and it occurs at the orbital, supraorbital, and the temporal region. It is of a severe intensity, and it occurs every once every other day or 8 times a day, and the duration is 15 to 180 minutes. So additional symptoms associated with the cluster headache is the ipsilateral conjunctival injection, lacrimation, which is lacrimation, nasal congestion, rhinorrhea, forehead and facial sweating, moises, ptosis, and eyelid edema. Restless or agitation is also seen in patient having cluster headache. So coming towards the tension type headache,
Sorry.
the location of
We
the
can say
tension.
that it will be around the eye area mostly, and eye symptoms would be involved with
Yes,
cluster
yes.
headache.
Mostly patient complain that they are having the problem they are having pain behind their eye, and their eyes are very watery, and sometimes it is also very red as well. I actually saw one of my colleagues. She was also having cluster headache yesterday,
Mm.
and she was complaining that she was having pain on the back of her eye. Her eye was very red, and she was unable to actually lift the eyelid as well due to the pain.
Mm.
So it is actually very evident in the cluster headache as well. So the tension type headache is a headache which most of the people have mostly experienced. It is a pressing, tightening kind of a headache, and it occurs on both sides of the head. Mostly, this area is basically covered. The forehead area is basically covered, and it feels like there is a band here which is pressing and tightening. And mostly, people complain that it feels like they have a band here which has been very put in a tight and a tight knotted condition, which is pressing against their head. So the duration, the intensity is of mild to moderate, and the duration can be more than 15 days or more than 3 months, and it can be there for hours, and it can be a continuous pain. So, less than 1% of people having tension type headache can be having photophobia, phonophobia, or mild nausea. Discussing about the migraine without aura, mostly cervicogenic headache are confused with the migraine because they are similar in symptoms compared to the cervicogenic headache. The migraine without aura is a unilateral pain, and it occurs in the frontotemporal region in adults and occipital region in adults. It is of a moderate to severe intensity, and it occurs for more than 14 days per month, and it can stay for 4 to 72 hours. So associated symptoms will be the patient will be having sensitivity with the flickering lights. He will be seeing spots in the vision, pulsating quality. He will be having a pulsating quality, as well as nausea, photophobia, and phonophobia will be present. So here are three pictures which demonstrate the three type of headaches. This is the cluster type headache. It shows that the patient will be having pain in the periorbital region behind the eye. The eye will be red and watery sometimes as well. The patient will be having difficulty in lifting this eye as well. Regarding the tension type headache, this area will be covered, which is like forehead. The patient will be complaining like they will feel like a tight band has been taut on their forehead area. And coming towards the migraine, this is the area which will be covered in migraine, and the patient will be having sensitivity. Most of the time in migraines, patients are having sensitivity to light, and if the migraine is without aura, associated symptoms as discussed will be like sometimes patient also complain that they are feeling like they are seeing spots in front of their eyes, which is related to the migraine. So the differential diagnosis, for the differential diagnosis of the headache, cervicogenic headache is of same occurrence in both male and female, while migraine is occur more in female as compared to male, and the tension type headache is also common in female comparative to male. So the lateralization, the patient will be having the cervicogenic headache, the patient will be having unilateral pain without the side shift. While in migraine, patient is having 60% unilateral pain, but they do have a side shift. In the tension type headache, the patient will complain of a diffused bilateral pain, and it will be present on the, which means it will be present on both sides of the head. The location of the cervicogenic headache will be occipital to frontoparietal and the orbital area, while the migraine will be frontal, periorbital, and the temporal area. While the tension type headache will be a diffuse pain. Right, like here in this differential diagnosis, the two most common things to be differentiated are the migraine and the cervicogenic headache. So if a patient is coming with the unilateral pain without side shift, it means that it gives an indication of the cervicogenic headache. While if the patient complains that the pain is unilateral but it is occurring with side shift, it means the patient might be having migraine. And if the frequency of the
So
headache,
side shift means here that if the patient is complaining that I have pain in the left eye or the left temporal area, as well as the pain is radiating towards right side, that is like
no, no,
मतलब
no,
कभी
the patient will say,
it can be either right, it can be left, it can shift sides, कभी उनको right
yes,
side पे हो जाएगी या कभी
yes.
उनको left side. It's
The
not
patient will say
particularly.
sometimes it's on the right side, sometimes is on the left side. I am unable to diagnose or locate the area of pain, but yes, I am feeling on one-sided headache, but it's not constantly on right side or left side. It keeps on changing the sides.
If you
This is
like, I don't know, but lots of my friends have migraine, so they always say that sometime it's right side, sometime it's left side. So
yes, it does occur
and
like
it
that.
stays on
yeah,
the same side, like unilateral, not side
it
shifting. Then
it's
diagnosed
not, so it's
cluster.
not
Yes,
bilateral and
basically what happens in the, oh sorry, I'm
no, no,
okay. So what happens in the cervicogenic headache is this, that it purely occurs because of a problem or pathology in the upper three cervical region. Mostly when we are palpating the patient's suboccipital area, we can feel the tenderness on the, if they are having the right side cervicogenic headache, the suboccipital region muscles at that area will be more tender comparative to the other side area, because the nerves of that side are pressed. While in migraine, this is not the case. We will be seeing stiffness in both sides, and there will be some occipital stiffness. There will be stiffness in the upper quadrant muscle, quarter muscles, and the scalenes as well. But the both side muscles will be stiff, and the range of motion in is also not that is also reduced in the cervicogenic headache. So this is how we can actually differentiate with the patient between the patients of cervicogenic headache and migraine. Okay. So so where were we? Acha. So coming towards the severity of cervicogenic headache, cervicogenic headache is of mild to moderate to severe intensity, while migraine is also of moderate to severe intensity. But tension type headache is of mild to moderate intensity, and the frequency if of the cervicogenic headache is chronic and episodic. While the migraine, it occurs 1 to 4 per month, while tension type headache, it occurs 1 to 30 per month. The duration of the cervicogenic headache is 1 hour to week, while migraine is 4 to 72 hours. Tension type headache, it stays there for days to weeks. The characteristics of the pain in the cervicogenic headache is a non-throbbing, non-lancinating pain, and it usually starts in the neck. While the characteristics of pain in migraine is a throbbing, pulsating pain, due to which the patient is unable to rest his head in any sort of position. They are feeling a constant throbbing, pulsating pain in every direction, which causes them difficulty in performing their daily tasks. Tension type headache is a dull kind of a headache which stays there. That is why its duration is also for days to week. The triggers of the cervicogenic headache is usually cervicogenic headache is triggered by the neck movement and posture. If the patient is sitting in a static posture for a prolonged period of time, they may be having initiation of the cervicogenic headache. And if and sometimes what happens is this: if a patient is moving their head in a certain direction, right or left, upward or downward, they feel that the pain has started again. And it is mostly related to the neck. There will be limited range of motion and pressure over the C0 to C3 level spine, which I told that there will be a lot of tenderness there, and the patient will complain that they feel some pressure, a lot of pressure in the back of their neck, which is like at the suboccipital region. While in the migraine, the triggers can be multiple. It can be with aura, it can be without aura. If like it is with aura, sometimes people start to have migraine if they with a lot of like lightning, with having consumption of caffeine as well, with perfumes as well. And if it is without aura, then it can start without any typical reason. The neck movement is not typical in the migraine, but cervicogenic headache is typically related to the neck movement. While the tension type headache, the triggers are multiple, as we discussed in the migraine, but and the movement is not typical, and it is not related to the movement. Tension type headache is mostly related to a stress. If the and migraine is as well. Mostly migraine and tension type headache occur when the patient is under a lot of stress. They feel like their migraines have triggered, or they are having that diffuse dull kind of a pain in their head. And when their that specific stress has been gone, they feel the headache has also been is also not there. So the associated symptoms for the cervicogenic headache is usually in the cervicogenic headache, associated symptoms are absent, or they are similar to migraine, but they are milder. Like in migraine, people might be having nausea, they might be having photophobia, phonophobia, but it occurs in at a milder and a very lower level with the patient having cervicogenic headache. And one associated symptom is like decreased range of motion in the neck. uh, while the patient having migraines, they will be having nausea, vomiting, visual changes, phonophobia, and photophobia. Coming towards the associated symptoms of the tension type headache, occasionally there is decreased appetite in patient having tension type headache, and they are also having phonophobia or photophobia. So I hope I haven't confused everything.
No, you're going good.
Okay.
It says it's non-lancinating. Does it mean like it's dull?
Uh,
The
mm,
character, I mean, the pain intensity, is it dull then? It's lancinating, sharp pain, right?
yes, you can say that.
So it's
Because most of the people say that they are having a constant type of
the headache.
pain here on on their on this side of the one side of their head and their face. And it is not that like sharp shooting, but yes, it is causing a lot of discomfort. Yes, we can say that. So there are some outcome measures, like specific questionnaires, which we can give the patient to diagnose whether the patient is having a cervicogenic headache or any other type of headache. The name of these questionnaires are neck disability index, headache disability index, the Northwick Park questionnaire, neck pain and disability index, numeric pain rating scale, and pain visual analog scale. The last two are most commonly used in order to rate the intensity of the pain, while the first four are used in order to assess the intensity, recurrence of the pain, duration of the pain, and they help us. Their score actually at the end of the questionnaire, the score help us diagnose the patient will is having what kind of headache. So coming towards the examination, for the diagnostic criteria set by the International Headache Society, pain localized in the neck and occiput, which can spread to the other areas such as the forehead, orbital region, temples, vertex, or ear, usually unilateral. indicates the cervicogenic headache. The patient will be complaining of pain which is precipitated or aggravated by specific neck movement, as we have discussed before as well, or sustained posture due to the stiffness of the muscle at that, because due to it occurs because the patient is having stiffness of muscle at that specific area. It leads to the irritation of the first three cervical vertebra and release the pain signal, causing activating the cervical neurotransmitter and leading to pain in the occipital area, temporal area, and the eye area as well. And at least if we are diagnosing the patient, assessing the patient will be having at least one of these following. There will be resistance of or limitation of passive neck movement, and there will be changes in the neck contour, texture, tone, or a response to active and passive stretching and contraction. There will be abnormal tenderness of the neck musculature due to the overuse of the muscle and the chronic stiffness. The tenderness will be present in the neck musculature. For the radiological examination, we will see that some abnormalities in the flexion extension, abnormal posture. There can be presence of fracture, congenital abnormalities, bone tumors, rheumatoid arthritis, or other disc pathologies, but not spondylosis or osteochondrosis. So there is a special confirmatory test for which is called as flexion rotation test. This test basically tells us what the patient is having a cervicogenic headache on at what side of the head, whether it is right-sided or left-sided. The sensitivity of the flexion rotation test is 0.91%, while the specificity is 0.90%. In the flexion rotation test, if the patient is having reduced range of motion, like 10-degree reduction in the range of motion from the anticipated normal range, which is 44 degrees, it is diagnosed that the patient is having positive cervicogenic headache in that side. In this flexion rotation test, the patient is in supine lying position and the head is off the table. The therapist basically holds the head and do the flexion and rotation of the neck movement on both sides, and then ask the patient on what side do they feel the pain, whether they are feeling the pain in the right side or the left side. And while performing this special test, the therapist will also look for restriction in the range of motion on the right and left side, and and they will consider the CGH positive for the side where they are having restriction, a 10-degree decrease in the range of motion of the neck, and initiation of the pain in their neck. So there are some red flags as well, which should be kept in mind. If there is a sudden onset of new severe headache and there is a worsening pattern of the pre-existing headache and with the absence of obvious predisposing factor, if the headache is associated with fever, neck stiffness, neck skin rashes, and a history of cancer, HIV, or other systemic illness, if a patient is having headache which is associated with focal neurological signs other than the typical aura, and if the patient is having moderate or severe headache which is triggered by cough, exertion, or bearing down. Lastly, if a new onset of headache if the patient is having new onset of headache during or following pregnancy, then the patient will fall under the red flag, and they should be referred for further investigations and the medical consultation as well. So, coming towards the treatment and management. The management of cervicogenic headache is intra-professional. Physiotherapy is considered the first line of treatment. Manipulative therapy of the cervical spine and the thoracic vertebrae actually and the therapeutic exercises regime are effective in treating the cervicogenic headache. There are other options for the treatment of the cervicogenic headache, such as interventional treatment, which will differ depending on the cause of the headache. And then we can use cervical epidural steroids as well, well, which can work in setting, which can steroids can work in this setting due to the theory that the pain continues sensitizing the cervical nerve roots and initiate a pain product producing loop involving nerve root and microvascular inflammation as well as mechanically induced micro injury. Unfortunately, cervicogenic headache tend to reoccur and can significantly affect the quality of life. That is why some patients may also benefit from simultaneous cognitive behavior therapy. So there is a little bit discussion about the cervical epidural injection. They are basically injected for multi-level disc or spine degeneration, and if there is some evidence that cervical epidural steroids has some benefit in treating the pain in cervicogenic headache. Steroids can work in this setting due to the theory that pain continues sensitizing the cervical nerve root and initiate a pain-producing loop involving nerve root and microvascular inflammation as well as mechanically induced microsurgery. Then we can use nerve block as well, which trigger point injection as well, radio frequency and radio frequency thermal neurolysis as well. Along with that, there are some medicinal treatment which are tricyclic antidepressant, muscle relaxant, and botulinum toxin. Botulinum toxin is basically a Botox injection, which is used to treat the adhesions in the tender muscle, and it helps in reducing the hypertonia of the muscles. So, coming towards the physical therapy management, which is very important for us. So, in physical therapy, cervical spine manipulation and mobilization, strengthening exercises, including the deep neck muscles and the upper quarter muscles, along with the thoracic spine thrust manipulation exercise, including the C1, C2 snag, are shown to be very effective. Um, uh, as per a research, it is reported that a 6 weeks physiotherapy program, including manual therapy and exercise intervention, was an effective treatment option for reducing the cervicogenic headache symptom and decreasing medication intake in both short term and at 1 year follow up. So, why do you think that we are working on the strengthening of the deep neck muscles and the upper quarter muscles?
Obviously, if muscles will be strengthened up, then they will have less trigger points and less stiffness in future.
Basically, what
Over think you did say in the start that deep neck flexors are over recruited, tightness हो जाती है, and upper quadrant muscles. So if person is in pain for that long time, then obviously the surrounding area, the muscles are going to be in hypertoned or hypersensitive होंगे. So once you start working on it, you increase and you decrease the tone. तो उनको relax. Once you relax that, because they are also one of the triggers to increase the cervicogenic headache. So it's going to ease the pain and symptoms in patients.
so basically, I want to correct myself here. What I said was that there is an overuse of yes, deep neck muscles as well. Due to the deep neck muscles are basically very weak, and they are while we are assessing the patient with the cervicogenic headache, they will be having deep neck flexors weakness. So while we are working on the strengthening of these muscles, the main aim of this exercise is to help the patient do the even distribution of weight, like the skull on the spine, cervical spine, so that there is no overuse of the extensor muscles and the superficial flexors of the neck. And when the pressure from the superficial flexors and extensors are reduced, there is even distribution of weight, and the reoccurrence pattern of the cervicogenic headache, which most people complain that once they get the treatment, after some time they are having recurrence of these pattern. There are the chances of the recurrence is basically reduced. That is why we work on the strengthening of the deep neck muscle. Basically, it is the activation exercise of the deep neck muscles.
I think even in the start as well, it says when you were just defining about, if you go up on the article, it does
Yes,
say
yes.
superficial muscles. I think deep, one of them are over recruited and one of them are less
Yes, the
recruited.
superficial one are over recruited and the
Over
deep ones are under recruited. So that is why we are working on the deep neck muscles. This is
strengthening, yeah. Obviously, the matlab, we'll will work to strengthen the weak muscles, और जो overworking कर रहे होंगे उनकी tone को reduce करना है. It's
Exactly,
the
exactly. In
rule
order
of
to
thumb.
get a super
Muscle
posture be
imbalance,
and not.
Yeah.
Sorry?
imbalance is
For muscle
you said
imbalance.
Yes,
muscle.
you are right.
So
Exactly.
you
Muscle imbalance
have,
is the right word to use.
yeah,
Very
so
right.
you have to work on the once you start correcting the muscle balances, the
इनसे
mechanics,
मसल कंफ्यूज हो गए
Sorry?
any kind of
से मसल
pain,
कंफ्यूज हो गया
any yeah.
नहीं, दोबारा से okay. I can explain again about it.
नहीं मैं
दोबारा
कह
से
रही हूँ कि वी कैन से कि मसल्स कंफ्यूज हो गए ना मसल इम्बैलेंस हुआ है तो मसल कंफ्यूज हो गए
बिल्कुल सही बात है सही है You are right.
Very nice. Are you done, Manu?
Uh, yes, I am done, but there is one last thing which I want to add. There is a very good exercise which is called as let me show you. It is called re-education of the craniocervical flexion movement. This exercise is actually used for the activation of the deep neck flexors. It is 3 to 4 step exercise, and the patient is in. Should I tell you the exercise? Explain you the exercise because we
Okay.
can. I can actually do the exercise right
Go
now.
on.
So the patient will be in a sitting position, in erect sitting position. The neck will be straight, the feet will be supported on the ground. First, we will start by activating, by doing the neck retraction movement. And the patient will do one thing that they will retract their neck, and the movement will be very minimal. They will be feeling pressure here and at the back of the skull. And they will hold this position for 2 to 3 seconds and do 5 repetitions each. After that, they will move towards step two. They will do one thing. They will retract their neck and they will look downward as if they are nodding. This is called retraction and nodding. They will hold this position for 2 to 3 seconds and they will do 5 repetitions of these exercise. And how they can assess whether they are doing this exercise right or not, they will be feeling pressure here at the front of their neck and at the backs as well, at the suboccipital region. The third one is isometric exercise. In this exercise, the patient will use these 2 fingers and put it on the both side of their face. Okay, they will retract their neck and they will nod downwards, and they should feel their fingers moving upward. And they will hold this position again for 2 to 3 seconds and then 5 repetitions, and then they will come back to normal position. Again, after that, they will use these 2 fingers, put it beneath their behind their head in the suboccipital region, and then they will retract their head and nod downward. The nodding will not the nodding movement will be very minimal. This movement will actually the hands will be resisting the backward movement of the neck, and the patient will be resisting the hands from their neck as well. Okay. So the last exercise is this: the patient will do retraction, and then they will move 10 degrees towards their left and look downward as if they are nodding. Hold this position again for 3 seconds, do the 5 repetitions, and then come back to the normal position. Then they have to proceed towards 20 degrees hold retraction. They will be looking downwards and they will hold this position for 2 to 3 seconds and 5 repetitions. The same will be done on the other side. This exercise will help them in activation of the deep neck muscles, and it will help a lot in relieving the pain. There is one last step in this exercise. It is done in supine-like position with a hard cushion or a pillow beneath their suboccipital area. The patient will be doing one thing. They will keep 2 finger as a reference here on their chin, and they will do the chin tucking and hold it for like 3 seconds and then relax and again do the 5 repetitions each. This phenomena is very good for activation of these muscles, and I most of the time I incorporate these exercises with the patient who are having cervicogenic headache, and I've seen very good results with this exercise. So I'm done.
Very nice.
Wow, it was
Thank you.
really great. Yeah. When you were telling the exercises, I was doing like retraction and things like that.
They are
But
very good actually. We are also having stiff muscles here, so yes, everyone should do it.
yeah, I felt
Yeah.
so good. And thanks
Headache
for
and
like discussing this topic because it has helped me. I always used to mix migraine and tension headache and then cluster headache, and now and that picture that makes the difference. That showed the difference between three of them, and then you explained the cervicogenic. It was very good.
I
Yeah.
hope
Good.
I have confused everything because at one time I thought that everything is mixing up and I don't know whether you are getting it or not. So I hope it was like
Yeah,
an
it's the
information.
chance जो चीज हमें समझ नहीं थी, we have got that.
Yes, it was definitely
Well, that's
a
great.
good
That's great.
presentation. Thank you, Mahnur. It was so good.
Thank you so much.
Yeah.
Thank you so
we
much
have
for having
only time. We have only 10 minutes, so you have if you have any Q&As, we can discuss that in minutes.
Whatever I wanted to ask, I
I don't have any questions specifically. If you have any question, you can ask.
Yeah.
One thing I have, like, sorry, मैं आप लोगों को तंग कर रही हूँ. एक question मैं पूछूंगी. So, how do you treat patients with the cervicogenic headache? What exercises do you prescribe?
अच्छा मैं तो करती हूँ ना कि I like this is my bed thingy and I ask them to lie down on their tummy, so basically they are facing down, and then the first step I do is obviously people like touching them. So
Yeah.
and I prefer doing the mobilization part and massage part as well. Obviously, I,
Okay.
I guide them with the exercises as well. So I try to mobilize basically the occipital region, and I do it with my elbow, and I
Okay.
get 100% result, and the patient is like, "Wow, you have done a magic." Yeah. So
The muscles there are actually very stiff, and it's a lot of pressure is actually needed to do the trigger point release here. So
yeah.
elbow is a good idea.
ये
आपके जो
मैंने एक्चुअली अपने ऊपर स्टार्ट किया था when I used to get these kind of stiffness, so I used
अच्छा.
to ask my husband or my mother to do this, and then I started with my clients because I got very good results on myself, and then I started doing it, and then obviously with the trapezius muscle and a little bit of massage with the hands, and then use your thumbs. हम कहते हैं कि बिल्कुल एंड ऑप्शन होना चाहिए, बट आई समटाइम्स ट्राई टू यूज बिकॉज अगर किसी की ज्यादा स्टिफनेस हो तो आई ट्राई टू यूज द
बिल्कुल
थंब,
बिल्कुल बिल्कुल.
otherwise I use the palm side of my hand, and then obviously guide the exercises at the end, mostly isometrics, and I use theragun as well. Obviously the vibrator is like kind of vibrating your head as well,
That's
but it gives very good result.
conditions. That's great. So
Benish, your mic is mute.
Sorry, because of cough, I have to every time go on to mute.
you had a question as well. You raised your hand.
Yes, I just want to add some points in addition with Amna, as you have said that what you people are doing in treating
Yeah.
cervicogenic headaches. So, if we talk about the cause, as you have said that there is some sort of a part of posture as well. So postural education is very, very important
Yeah,
because when we talk
yes.
about the deep neck flexors activation, whatever we are doing is bringing your chin back to the neutral, so more focusing on the center of gravity and the line of gravity. Okay, so
Yeah.
and another exercise I appreciate what you have added is more like, so Mackenzie is saying the same thing, lying on your back and just bringing your neck a little bit more, so you're using your two fingers as a reference point and you're still doing chin tuck in, so engaging your deep neck flexors. So that's really a modern approach how cervicogenic headaches should be treated. And another thing is snacks is very, very important, and it works very well for upper cervical irritation, because we are talking about everything C0, C1, C2 and C3.
Yeah.
Upper cervical spine irritation works very well with snacks as well. So and these are the things which we just add in. It totally depends on the motivation level or how energetic you are with your patient, telling them about, I am confident that this exercise will be helpful. And you, if you are sure, your patient is sure, your patient believes on what you are adding will be right. Otherwise nobody will be doing what you are guiding them behind the camera.
Yeah.
Exactly, you are very right about it. You
Hmm.
have to build trust among with the patient, because if we are not sure about the exercises, the patient will not be doing it, and if we are not explaining it well, then
Hmm.
the same will happen. You are very right about it.
And
Along with that,
yes,
I
sorry,
think
along with
they
that, yes.
like giving the manual snacks and
self snack.
manual massage stuff. It tends to be very. I mean, it's long time since I have done manual because in NHS we don't get time. We only have
Yeah.
like 20
Yeah,
with
I
one.
do it on a regular basis. Okay.
It's a long time since I have done any manual, so I've literally forgotten every basic
But
thing
in
of
Foster, you can get people to self snacks exercises with the
self.
topic, and
Yeah,
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 and
self.
it's
Yeah.
As per the
So
current research
I
evidence,
was just
in the isometric strengthening exercises are very good in
Very good.
improving these kind of things,
yeah.
because
I
it improves
always
the blood circulation.
I even add aromatic strengthening when a patient comes with shoulder issues because their
Yeah.
neck is always overloaded, always and
Yes,
Yeah.
it
always.
is.
So
Yes, it
it's
is.
neck though. I mean, I always take notice on a joint above and below of the
Yeah.
involved joint. Thoda, you have to involve them to sort of take the overload because it's
So we
very
can say kinetic chain, huh? Remember last time we
yeah.
discussed
Exactly.
Your
We
joint
have to look on
below.
every aspect of thing. Na? Like we have to look on the biomechanics on the
holistic.
associated structure as well. Because if someone is having problem in their neck, they might be having problem with their pelvis as well. If we are not looking at the whole posture, the problem will be reoccurring. So it's important to do that. I think you all will be aware with the neurokinetic therapy, the which works on like focusing on the kinetic chain and looking at the like underactive and overactive muscle. I
Yeah.
usually follow this concept in treating the patient, and it actually works a lot. It's very
Oh,
effective.
it does wonders in shoulder. I mean, instant changes in the mechanics. I just add one more thing because we are discussing the topic of cervicogenic headache. It's very cervicogenic dizziness as well. So
Yeah.
all symptoms can give patient a dizziness because your upper cervical muscles are very 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 sensitive. If you look at the fiber arrangement of your in a cross section of your upper cervical, so you've got like 160 fibers per gram, which is compared to your thumb is only 16 fibers per gram. So that much sensitive your upper cervical muscles are because they are coordinating. They are not just only doing the movement, but they have got a very strong somatosensory connection. So they are efferent fibers to your brain. So
Oh,
once they get tight, when they get tight, and especially when you're doing your shoulder movements and stuff, they get tight. The efferent can be disturbed. That efferent between your brain, so that can give you dizziness. Person can feel, okay, I'm going dizzy. So in cervicogenic dizziness and cervicogenic headache, these are two very like it's like brother sister, very close topics.
yes.
I was actually rewinding all that training that I had in cervicogenic dizziness. I just took a CPD recently. So I've 90% of the stuff that you have added, like your deep muscles are weak and your superficial, it's exactly everything that goes on cervicogenic dizziness. So it will be actually a really good topic to now come across after that in our next CPD, so we can sort of interrelate.
yes.
Um, very close topics, and there's a very good treatment for your cervicogenic dizziness as well. It includes a little bit of vestibular rehab as well, but vestibular rehab is completely different to cervicogenic rehab, cervicogenic dizziness
Also,
rehab.
no, I'm a vestibular rehab
So
specialist
is
as
the
well.
psychogenic? Sorry.
I'm a vestibular rehab specialist as well. Remember, I went to Dubai in
Yes,
2018.
yeah, 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 yeah,
I
yeah.
did that course. Yeah.
Were you going
So
to ask,
yes,
Manu?
I was asking. Is cervicogenic headache also felt on one side of the head, or it's felt on like both sides, and the person is feeling dizzy like everywhere? Like there are times now when person is doing like side shifts
So
or
it's different. it's different to true vertigo. Your true vertigo,
Mm-hmm.
your vertigo, benign positional vertigo is basically more peripheral because your vestibular system is engaged, right?
Yeah.
Your system in your ear. So in that, it will be like true spinning. That's a true spinning where you feel like, okay, my environment is spinning around me. That's your benign positional vertigo. So that's your
Mm.
vestibular system is compromised.
Basically, it's three types of
Cervical, yeah.
situations. In
In
one, you
cervical,
feel that
like,
your environment is spinning. In the other, you feel that you are spinning. And the third
you
one,
are
the worst one, is like it's both.
both,
It's both.
yeah. Cervicogenic dizziness, you will feel a little bit of lightheadedness. It's more like a lightheadedness, like you are spinning. However, in vertigo is like a true spinning where you feel like everything is spinning around you. And cervicogenic dizziness, it stays for minutes. It's very episodic, and it's normally combined with neck movements. It will come with neck movements. However, vertigo can come anytime, or the other kinds of dizziness are not much combined with your neck, especially when your neck is in torsion, where when you're actually disturbing the afferents. Yeah, if you I can tell you, if you put your fingers in your upper cervicogenic muscles now, and if you
Hmm.
move your eyes, you're gonna feel your muscles working. Move your eyes fast, you're gonna feel the afferent
Yes,
going.
you are right. I
You can
can.
do you can do
Yes,
that.
I can. I can
So
feel the contraction.
that's the survival. So it is connected to your senses. It takes that somatosensory afferent, and it actually can do that communication between your brain. So you've got your three
Sorry, I think our meeting is gonna end in 2-3 minutes.
yeah.
Okay. So
We are
basically, there is an occipital nerve, which starts from here and it supplies the eye area, the greater and lesser occipital nerve. That is
yeah,
why when we are moving our eye, we are feeling the contraction here. I think
yeah.
this might be the reason
Because
of the business.
it's because your deep cervical neck flexors, they are working. They are sending those efferents. So whenever your visual system